Thank you, everyone, for joining us today. This is the Chester County Beekeepers Association Women's Bee Group Speaker Series. And tonight we have Dr. David Golden, who will be presenting on understanding bee sting allergies for beekeepers. Dr. Golden is an allergist, immunologist, and a world-renowned expert on bee sting allergies at Johns Hopkins University in Baltimore, Maryland. Dr. Golden directed a research program on insect allergies at Johns Hopkins for 30 years. He is now a part-time associate professor of medicine at Johns Hopkins. He also established a private group allergy practice in Baltimore and was allergy division chief at two community teaching hospitals. He continues to contribute as an educator and a member of the Allergy Guideline Task Force, and he also serves on the editorial boards of various allergy medical journals. He has presented to various beekeeping organizations, including the Eastern Apicultural Society annual meeting in August 2024. So Dr. Golden, thank you again so much for your time. I think this will be so valuable for our members, and I will turn it over to you. Thanks again.
Great, thank you. Thank you for inviting me. I have spoken to beekeeper groups from time to time, and I always enjoy it. I do this because in my training in allergy immunology many years ago, I was assigned to take over the insect allergy research program at Johns Hopkins in its early stages, and that was 40 years ago. So it's been an interesting ride. And I've certainly learned a lot about insect sting allergy, and I've learned a lot about the stinging insects. I've worked for many of those years, with an entomologist from the University of Maryland, and it was always a joy to spend the day with her when we would deliberately sting people with honeybees and yellow jackets and hornets in order to do studies on what makes people react or not react in certain ways, and we'll talk about that and some of what we found. But those days when Dr. Nancy Bryce would sit with us and just talk about entomology were some of the most fun I've had. Most of our insect allergic patients are yellow jacket or and I'll say yellow jacket, which kind of includes hornets and wasps, pretty much everything that's not a bee, other than those nasty stinging fire ants, if you go a little further south than where you and I are located. But I'll come back to that also in a moment. Let's start with just a few numbers. I pulled these off of several websites. There's a group, I'm not sure their origin or mission exactly, Be Aware, that promotes, I'm not sure where they get all their facts. Between 5% and 7.5% of Americans are hypersensitive to insect stings. Well, it depends what we call hypersensitive, and I'll explain more about what are allergic reactions or hypersensitive reactions. 16 million Americans are living with a potentially life-threatening bee sting allergy. Well, that's overstating it probably, but the point is that a lot more people are allergic to insect stings than you might think. In studies years ago, we found that there were some 3% of adults gave a history that they had had a systemic allergic reaction, not just local. And I'll try to explain those things a little bit better in a minute. A lot of emergency room visits every year for insect sting related allergic reactions, 60 deaths per year. It used to be for a long time, all the data, the US data, were saying 40 deaths per year. We always said that was an underestimate. The most recent data are showing more than 60 deaths per year. That's not a lot. On the other hand, it is. In terms of anaphylaxis, people die from allergic reactions to bee stings, food allergy, which gets a lot of press. There are probably as many insect sting deaths, maybe slightly less than food allergy deaths per year in the US. So it really is second only to food allergy as the cause of anaphylaxis and cause of death. And in adults, it is it's the most common cause of severe anaphylactic or allergic reactions. People who should be carrying an epinephrine injector seem to always forget or not have it with them or not use it. That's a whole another area of how we try to help people live with this allergy and not. I was commenting, I think, before we started that we don't want to over worry, but we also don't want to under worry. And we see a lot of both people who are much too worried about what they think is a severe allergy, and people who brush it off and say it was a fluke, it'll never happen again. And unfortunately, they can be very wrong about that. What most doctors don't seem to know, uh, other than allergists, is that there is a treatment, venom immunotherapy, allergy shots. Like there's allergy shots for hay fever allergies or cat allergy or dust allergy, purified bee venom and other venom um, treatment is available that is the most effective kind of allergy shots. It almost 100% eliminates the danger of severe allergic reactions to stings for people who need it. And there are a lot of people who are worried, maybe worried too much, probably because they've been given wrong information, and people who are interested in being treated, but who we might say don't really need it. So there are shades of how much good the treatment can do, but no treatment is harmless. And we want to target it for the people who need it the most and not have people worry for the wrong reasons. Um, so these are some interesting statistics that I've asked beekeepers to tell me about. 58 stings per year on average. That's not what I hear from beekeepers. I hope you'll tell me what you all think. Uh, and I don't mind being interrupted a little bit if I'm tossing this out there because that seemed like a lot to me. Is that a lot?
I
No, is
No,
the answer.
no,
No?
No.
yeah.
no.
Okay, that's what I thought. I hear yeses and nos, which I guess is what some people do. People ask me, do some people just attract stinging insects and get stung more than others? And that does seem to be true. And there's been a little bit of research on that, but nothing very revealing. Uh, Half of beekeepers with a bee sting allergy wear fully protective clothing. Well, I'm not sure how to interpret that. It depends how bad the allergy is. If that's saying the opposite, that half of beekeepers who should wear more protective clothing don't, that might be true. Just like they may not carry their injectors or get or look into the possible treatment to prevent reactions. Um, and does beekeeping, lastly, does beekeeping increase the risk of systemic allergic reactions? Yes, it does, only because you get stung more often than the average person. And it turns out that the frequency of stings is one of the things that can bring out an allergy. And that's true for other allergies. People take penicillin a million times in their life with no problem, and all of a sudden one day they're allergic. And we see actually this in children who sometimes get repeated courses of an antibiotic. So by the second or third or fourth time they get it in the same winter, they'll end up being allergic to it. So repeated exposure can bring on an allergy. And obviously that's more possible when you have frequent or daily exposure than compared to the average person. So beekeeping is a risk factor for becoming allergic to insect stings. That's true. Um, the uh, I hear a lot of different stories, and I'm going to pose these few vignettes and say like, what's wrong with this story? So, a 47-year-old man was stung by a bee with a normal reaction, but 2 days later went to the emergency room for progressive redness, swelling, and soreness, and was treated with oral antibiotics for an infection. They called it cellulitis. They actually wanted to admit him for intravenous antibiotics for this terrible infection that was climbing up his arm. What's wrong with the story is that it's medically, uh, I guess nothing's impossible, but it's nearly impossible for that much infection to set in under 48 hours from a sting. It just doesn't happen. 4 or 5 days, maybe. And an infection from stings is incredibly rare anyway. No, this was an allergic local reaction. So we'll get into terminology. Reactions can be normal, which can involve some itching, pain, swelling. It can be local in the area of the sting, but that can be a normal local reaction, itching, pain, swelling. Or it can be what we'll call a large local reaction, which is large, it's local, and usually delayed. Um, but it's local. And it's an allergic reaction, and it can creep up the arm. So I don't know if any of you have ever had this, but a large swelling, let's say you get stung on the hand or wrist. In some cases, the person wakes up the next morning with swelling up to the elbow and a red streak going up into the underarm. And an emergency room doctor will see that and say, oh, you need intravenous antibiotics, because that's the way infection can look when it drains to the lymph nodes. But in this case, it's an allergic lymphangitis, not an allergic lymphangitis. And emergency room doctors get fooled all the time. So that's not infection, that's allergy, but a local allergy, and not actually dangerous. The treatment for that is put ice packs on it and it'll go away. 1 week later, however, he was stung again, and after 12 hours developed progressive swelling. He was treated in the emergency room with an antihistamine, Benadryl, and steroids, prednisone, and a few days later developed itchy welts and hives all over that lasted for months. The insect was assumed to be a honeybee because the stinger was left in the skin. So what's wrong with this story? Honeybees are not the only stinging insects that leave stingers in the skin. It's often said that, oh, because a sting, and stinger is the wrong term, I'm told also by the entomologist. It's a sting, not a stinger. But honeybees do always leave the sting in the skin, but so do the meanest of the yellow jackets, 25 to 50% of the time leave the sting in the skin. So the fact that the stinger was left in the skin does not prove it was a honeybee. That was mistake number one here. But was an allergic reaction? That's a finer point for allergists to debate the way it happened. It just so happens that there are people who develop chronic hives. They get stung, and 5 to 10 days later, they start getting hives, and it goes on for months and months and months for no apparent reason, and then it goes away and it doesn't come back. So story number three, or same patient actually, because he was stung again 2 years ago with no reaction. The insect was assumed to be a honeybee because his wife was keeping bees. The hives were relocated to a different property. So again, what's wrong with this assumption? Well, don't blame the bees just because his wife was keeping bees. I did have a patient very much like this who insisted that it was a bee that stung them because they were walking past a property where the owner keeps bees. And the testing proved it was definitely not a bee that stung this person. But they'll always blame the bees when they see the hives. The blood test in this patient, and it's all about one patient, turned out to show positive to yellow jacket, hornet, and wasp, not to be very weakly positive to honeybee. That's another story. It's a cross reaction. The skin tests were actually negative to honeybee. And we counseled the patient about these swellings and reactions and what to believe and what not to believe in. They've been fine. But it just shows you some of the things that we hear that are simply not true. The person who goes to the emergency room is inevitably going to be told that the next one will kill you. And although I started out showing you that more people die each year than we thought from bee stings, statistically, if you start looking at that as far as the number of people with allergies who get stung, the chance of you dying, if you have an allergy to a bee sting, the chance of you dying from an allergy to a bee sting is about the same as the chance of you dying from a lightning strike. So it's highly overrated. I don't have to tell you what honeybees look like, but most people have no idea and routinely blame the wrong kind of insect or say it was definitely a bee or definitely a yellow jacket when it definitely wasn't. So there are three main families. The bees include honeybees primarily in what we deal with as allergies, but bumblebees, greenhouse workers actually often become allergic to bumblebee stings because they are used for pollination in greenhouses. And I mentioned the vespids, the yellow jackets, hornets, and wasps are all very closely related. The wasps, paper wasps, are a little less closely related to the others. And the stinging ants, fire ants mainly in this country, but jack jumper ants in Australia and other kinds of stinging ants in different parts of the world. Those groups are not related to each other. So if any of you happen to be allergic to fire ants here in the US and you're going to Australia, don't worry, you're not allergic to jack jumper ants, at least not yet. If you go there and you get stung a few times, you may very well become allergic to them. And then there's the lookalikes. So we're going outside the bee area here, but again, people, including me, can't really tell the difference necessarily, especially from a fleeting look. But the top left is a yellow jacket, and the bottom right is a Polistes dominula wasp, paper wasp, that has the same yellow and black markings, To the trained eye, it has a different wasp waist, as it's called, and the feet dangle when it flies. See, I've learned a few things from my entomologist. Um, and the white-faced hornet or bald-faced hornet that builds those football-shaped nests up in the trees that are very vibration sensitive. You don't want to be weed whacking or using a lawnmower anywhere near this nest because they will swarm and attack you. And the fire ants I was talking about, which is why you definitely do not want to go barefoot on almost anywhere in the southeast third of this country, especially the Gulf states. Uh, Fire ant stings in the Louisiana and Texas coastal areas outnumber yellow jacket and bee stings. There's often things said about what works or doesn't work to prevent getting stung, and there are misconceptions. This was actually written for me by that entomologist to make the point that fragrances and bright colors and floral clothing really don't attract stinging insects. Insect repellents don't work to repel or avoid insect stings. And running and flailing your arms, as we all know, definitely doesn't work either. But a little common sense, but not. And this probably applies more generally to the vespids, the yellow jackets, and hornets and wasps. The best ways to avoid getting a honeybee sting is to respect them and they'll behave. And if you behave, they'll behave. Am I getting that right? Because that's the way I always felt about honeybees. But so most of these effective measures are targeting the things that attract the yellow jackets and hornets and wasps, mainly food. You definitely, if you're allergic to insect stings, you definitely don't want to be drinking from straws or soda cans or bottles outdoors. Yellow jackets are just the right size to fit in a straw or soda can. And every year I hear about people getting stung in the tongue or throat because they didn't look before they drank. So let me go back, as I said I would, to the different kinds of reactions that can happen to stings, and I'll give you these examples. This 46-year-old woman, people come to us for different reasons, not always because they know they're allergic. This woman requested testing for insect allergy because her cousin had a near-fatal reaction to a sting, and ever since then she's avoided going outdoors and outdoor activities because she's afraid. She thinks she was stung as a child, but never had an abnormal reaction to a sting after that. And when I show this to doctors, I'll ask them questions, what's the right answer here? And the right answer is that we explain and hope that we can persuade this patient that testing is not advised if you've never had a reaction. And there's a very good reason for that. And that's because of something we call asymptomatic sensitization, which means that you do have the allergy in your system, but you don't have the symptoms. And this is really common for every allergy, whether it's cat allergy or peanut allergy or insect sting allergy. There can be 20% or more of the people in this country who have the allergy, and that's true for insect stings. 20% or more of the adults in this country would show positive on a test for allergy to either honeybee or yellow jacket. But most of them will not react if they get stung. So, and we don't know why. That's a Nobel Prize winning question as to what makes the body react or not react. But doing a test doesn't prove you are going to react. It only proves that you've been stung, you've been exposed, and it shows that you made an allergy in your system, but it doesn't prove you're going to react. So we don't recommend testing people who have never had a bad reaction because there's a 20% or more chance they're going to show positive, and then they're going to be really scared because they think that means they're going to react, but it mostly doesn't. So we just don't do it. And we wish we had a better way of detecting who is going to react versus who's not going to react. And we recognize some risk factors, but the test is not the absolute determinant. Other questions, should she carry an EpiPen? Mostly we're going to try to counsel this kind of person to be a lot less afraid. Everyone has a chance of getting stung. Everyone has a chance of having a reaction to a sting. The population risk is 1.5% that you're going to have a reaction to your next sting, even if you've never had a reaction to a sting before. So everyone has a chance of having a reaction, but we don't recommend the test. This other 32-year-old man had a history of severe and prolonged swelling from previous stings. And he stung on the leg, and after 15 minutes, he gets itchy welts and hives all over his body. His lips swell, his hands swell, but he doesn't get any swelling in his throat. He doesn't feel dizzy. He gets better after an hour, goes to the emergency room the next day because of the leg swelling, and they give him antibiotics, as I told you before. So this is the large local reaction I was talking about. If it's just large local, but not in his case, he now has become more reactive. He now had a systemic allergic reaction, not just local, but parts of the body that are distant from the local area of the sting. So if you get stung on your hand and your arm swells up, that's local. If you get stung on your hand and your face swells up, that's systemic. So yeah, hives all over, swelling of the lips and hands. So it was systemic, but it wasn't anaphylaxis. Anaphylaxis is a term that goes beyond hives and swelling and has to involve the throat or breathing, or has to involve the circulation, like where your blood pressure drops and you get dizzy or pass out. That's called anaphylactic shock. So if there's no trouble with blood pressure and there's no trouble with breathing and there's just itching and hives and swelling, that's still a systemic allergic reaction, but it's not anaphylaxis. And there is a fine difference, and there's a big difference in whether you're in danger from future stings or not. And we'll definitely come back to that. I'll skip the questions here, and I may even skip some slides. I want to try to, why isn't it advancing? Okay, I'll try to keep it going. No, it went backwards. Let's try again. Okay, so large local reactions. I've already explained. I'm sorry about that. That they're large, they're delayed, they're allergic. They don't need any special treatment. But if they're really big, sometimes a few days of a steroid like prednisone could make them go down faster. But what's the danger involved? That's always what it's going to come down to. What's going to happen on the next sting? Am I in danger? And danger usually means you're going to have trouble breathing or you're going to go into shock. Getting itchy and rash is scary and can be very scary, but it's actually not dangerous. No one ever died from hives alone, not if it doesn't get internal, so to speak. So what's the chance if you've had a large local reaction? What's going to happen in the future? There's in different studies, 4 to 10% chance of a systemic reaction. People with large locals tend to just have large locals, but there's a small chance of a systemic reaction and a less than 3% chance of anaphylaxis where they would actually need to use an EpiPen. So that's pretty low risk. Although that's a personal value or personal judgment as to whether less than 3% chance of anaphylaxis sounds like a low risk. Like, would you want to be tested and get allergy shots because you have a less than 3% chance of anaphylaxis? Or which some people would very much, or would you say, that's not so bad. I don't want to go through all the testing and shots. I'm not worried about it, which many people would. So I'm pointing out that what we do oftentimes is called shared decision making, where we explain what we know and what we don't know, and then we discuss what works out the best for you, because there are recommendations. Like, the recommendation is not to treat this person, but the recommendation in some situations doesn't suit everyone, and we have to give you or the patient informed choices. Same with whether should I give you a prescription for an EpiPen? Again, shared decision making is going to come into this about whether you want or don't want or really need or don't need to have an EpiPen. But if you are a beekeeper and you get stung every year and you get these huge swellings and you're tired of it, you may want to go on the shots because it will reduce those large local reactions. It is very effective. So even though we're not doing it to save your life, there's still maybe a very good reason to consider being immunized if you're tired of these large local reactions. Okay. And you definitely don't want to drink from that soda can with the straw, because that's how this 57-year-old gentleman landed up in the emergency room with chest pain. And when they ruled out a heart attack and they looked down in his stomach because they thought it was his esophagus going into spasm, his esophagus was fine, but this is what they found in his stomach. They called it a bezoar. If you don't know, a bezoar actually means a hairball in a cat, for example. When they cough it up, it's a bezoar. But so this was a take on that term bezoar. But as another letter writer in the New England Journal of Medicine said, this is not a bezoar, it's a yellow jacket zoar, which was supposed to be a medical joke. No, let's skip that one. Kids are different than adults in many ways, but what we noticed at Hopkins many years ago is that most of the children who were coming in because of systemic allergic reactions to insect stings had these cutaneous, the skin reactions. They broke out in hives, their face swelled, but they didn't have any trouble breathing or dizziness. So that's a mild systemic, and it's technically not even anaphylaxis. But that wasn't the case in adults. Most adults, besides having the skin manifestations, urticaria is hives, angioedema is swelling. But most adults also had trouble breathing, wheezing, lightheadedness, low drop in blood pressure. Sorry for all the technical terms, or even loss of consciousness, which was distinctly uncommon in children for them to go into shock. So they're very different patterns in children and adults, and children tend to have less severe reactions. They can have very severe reactions and even fatal reactions, but they're more on the spectrum of milder reactions than adults are. Adults are much more prone, as it showed, to getting the potentially very dangerous part of anaphylactic shock. How fast does the reaction come on? These are called immediate allergic reactions for a reason. They're fairly immediate, usually 10, 20, maybe 30 minutes after the sting. And in this case, this analysis of about 3,000 different patients in a registry many years ago, you can see that some 75% came on within 20 minutes and 85% within 40 minutes. But there were a few stragglers. It's always strange and scientifically hard to explain how someone could get stung and 2 hours later go into anaphylactic shock. But it has happened. What about bee sting allergy in beekeepers? There have been a number of studies for different reasons looking at the occurrence of allergy in beekeepers. This is a summary of 6 or 7 different studies that I've seen. So here we're totaling almost 1,500 beekeepers, and 24% of them had a history of large local reactions, and 20% had a history of systemic reactions. So those numbers are 3, 4, even 5 times more than the general population.
I said excuse.
So this does tell us that becoming allergic to bee stings is more common in beekeepers than in the general population. And as I said, it's I think inevitable when there's repeated exposures. But here's another study of almost as many, over 1,000 beekeepers in Germany, where, and here's another number, 30, an average of 30 stings per year. Here only 4.4% had systemic reactions. That's way lower. 18% had large local reactions. So that was almost as high. So you can see that in different communities, the estimates come out differently. And I can't explain that necessarily. After reading the papers, I couldn't see where there was any difference in terminology or any other reason that they would come up with these different estimates, especially when the median number of stings wasn't all that different. But there are different numbers that come out of different studies. So as I kind of said a little earlier, but the question that everyone really wants to know is what's going to happen next time. When someone comes to see me because they think they're allergic or they're afraid they might be allergic, what they're really asking is what's going to happen in the future. And we have limited ways of knowing that. We can't totally predict it. Things that help us to predict it are what happened last time, the history, and the tests that we do, and other known risk factors. So here's the history: mild, moderate, severe history. Mild is the skin reactions, the breaking out in hives and swelling of the body on the outside. But what this is showing you is that the more severe the history, the more severe it was last time, the more the chance you're going to have a reaction if you get stung. This is just showing you the chance of having a reaction. It just so happens that it also predicts the severity of reaction. So the more severe it was last time, the more the chance it's going to be severe next time. That might sound like common sense, but I'll show you where that led us as far as debunking one of the myths. But this study was, and this is where we were literally stinging people at Johns Hopkins who had previous allergic reactions and refused treatment. And we thought we could learn a lot about why they react in different ways. Like in this case, The red bars are Vespula maculifrons. These are the ground nesting yellow jackets that you run over with your lawnmower and they swarm and chase you. The blue bar, on the other hand, is a different species of yellow jacket that I can't tell one from the other. That is different both in behavior and in potency. So what you're seeing here is that let's just look on the right side. Even those severe reactors who previously had very severe reactions, when we stung them with the guys in the red bar, they had a much higher frequency of reaction than if we stung them with the different kind of yellow jacket in the blue bar. And this goes to, from our point of view, this goes to the person who comes in and says, or, I might ask you, if you came to me because you're allergic to peanuts, I would, on your first visit, I would ask you, incidentally, I would ask you about penicillin allergy and lots of things, but I would ask you, have you ever had a severe reaction to an insect sting? And you might say, oh, yeah, I had a really severe reaction 10 years ago, but I got stung last year by another yellow jacket and I had no reaction at all. So I'm okay, right? This study says no, not necessarily, because it might have been the other kind of yellow jacket. And now if you get stung next time by the original yellow jacket, the one in the red bar, then you might very well have a reaction again, especially if it was severe last time. I'm saying this because that variability happens a lot. People who are allergic, but they don't always react to a sting. They react this time, but not next time, and they might react the time after that for a number of possible reasons. This is one of them. One of the other reasons is because yellow jackets deliver between 2 and 20 micrograms of venom per sting. And that's a tenfold difference. So there is such a thing as a stronger sting or a lighter sting. And someone might very well not react to the sting that only delivered 2 or 3 micrograms, but they might react to the sting that delivered 20 micrograms. So that's another potential reason. And that's not true in honeybees, because honeybees deliver the full 50 microgram dose of venom with every sting, because that's all they've got, and they give it all. So I was talking about the history as a predictor, but why can't you just do a test and tell me what's going to happen next time? Well, first of all, because like I said, 20% or more of adults are positive to the test. In fact, if you were stung this summer, there's a 40% chance you're positive, but it's going to get weaker and potentially go away over the coming months or years. So a lot of people with positive tests, that doesn't actually prove anything, like I said earlier. It doesn't prove you're going to react. It only proves that you were stung. And testing doesn't prove how severe. Some people have very strong tests and have very little reaction. And some people have barely detectable insect allergy on the tests, and they have near fatal reactions. So there's a limit to what the tests can tell us. And it's really, we say that it's confirmatory. If someone has a clear history of a severe reaction and we do the test and it's positive, then we've confirmed that you're allergic to it. But the test in itself can't make the diagnosis. So as far as what the tests mean, like I said, a negative test is pretty good. It means you're not going to have a reaction in the future. But a positive test only proves you've been stung. And we know that a positive test can bring a lot of fear with it and affect lifestyle. Even though we might tell you you're at very low risk for a reaction, there's some people who can't help but being very fearful after that. So that's why I said earlier that only people who had anaphylaxis and are therefore in danger of future anaphylaxis, they're really the only ones that we recommend should be tested and treated. But everyone who's ever had a reaction has been told by their friends, relatives, and doctors the next one will kill you. And I've already said that's not true. It always gets worse. No, it doesn't always get worse. It actually usually doesn't get worse with each thing. Oh, you'll outgrow it, especially to children. Well, actually, we did a 20-year follow-up study of children, and it turns out that the ones with the moderate to severe reactions still had a 30% frequency of reactions when they were 20 years older. So no, you don't easily outgrow it. You can, and a lot of people do, but it's incorrect to say that you're young, therefore you're going to outgrow it. As I mentioned earlier, because I hear this so often, oh, I've been stung so many times in my life, so yeah, I couldn't breathe and I passed out, but it was a fluke. It won't happen again. No, if it happened once, it's 50 to, if it was that bad, there's a 50 to 70% chance it's going to happen on the next thing too. And oh, I'm not worried because I'll just take a Benadryl, it'll take care of it. No, it will not. Antihistamines are not effective treatment for anaphylaxis. For one thing, they take 30 minutes to work, and by then you're either dead or you're not. So antihistamines are not effective treatment for anaphylaxis and do not prevent anaphylaxis. So how do we predict who's going to have the severe reactions? Well, we've learned part of this, as you should see in this slide, by stinging people. This sting device was invented by Dr. Bryce, the entomologist that we work with. So first question, do systemic reactions always get worse? If you got stung or your child got stung and broke out in hives all over and had a swollen face, which scared you, and you took them to the emergency room and you were told they were going to die next time, is it really going to get worse next time? Well, in the 259 people we stung in this study, 2 of them got worse. They did have these skin reactions, and when we stung them, they had some throat tightness and breathing discomfort. Nobody went from mild to severe. No one even went from moderate to severe. So yes, it can happen, and it does. We know that, but it turns out to be the exception rather than the rule. So whatever happened the first time you had a reaction to a sting is likely to be what would happen in the future. Unfortunately, I hate to say this, but when it comes to those fatalities I mentioned earlier, half of the people who die from insect sting allergy reactions die on their first ever reaction. They didn't know they were allergic. Like I said, whatever is going to happen to you may happen on the first sting. Or the first sting reaction, I should say, not the first sting. So as I alluded to, the children on the bottom of this slide were studied because the children who only have these skin reactions, and it turns out that they have a less than 3% chance, 1.1% in the Schubert study, of getting worse. And in adults, between 2 studies that were published, it also comes out in that less than 3% range. So as I said earlier, that's considered low risk. Less than 3% is a lot lower risk than 50 to 70%. But some people will accept that and others won't. But this is what led us to say that people who did not have the breathing problems or the circulation problems don't need to be immunized because their risk is fairly low. What can make a reaction more severe? Lots of things, actually, including alcohol, exercise. You see highlighted here psychological burden, which is the European term for stress. There's some interesting factors that actually can make the difference between a mild reaction and a severe reaction. But the top ones you see at the top of this chart are age, mast cell conditions, if you've ever heard of those things, which are more common in insect allergy than in the general population. So this just summarizes some of what I've been saying. The chance of a future systemic reaction and the chance of it being severe. So if someone had previously a very severe reaction, the risk is pretty high. If it was kind of medium, the risk is still significant, shall we say. But if it was only a skin reaction or a large local reaction, the risk is relatively small, but never zero. And those are the ones where we say the testing and treatment is not required. It's optional. It can be discussed. It may be desirable for some reasons, but it's not required. Same thing with prescribing epinephrine autoinjectors. We divide people into low risk and high risk. And the high risk, absolutely, of course, they need to have an epinephrine injector, at least until they're protected by the allergy shots. But there are a lot of people who are lower risk, like the ones I've been saying who had skin reactions or large local reactions or who've had venom immunotherapy. Again, the risk is never zero. So we have a whole discussion about whether they do or don't really want or need to have an epinephrine injector if we consider them low risk. So I went through that at a pace, but I wanted to communicate as much as I could about the kinds of reactions that occur and how we approach it as far as taking a history and doing tests and trying to give some people some idea of what are the chances of you having a reaction and how bad might it be in the future and what we can do about it. I really didn't go into details about those allergy shots. I'm happy to answer questions about it. I thought I would just maybe stop there and leave lots of time for questions.
Thank you so much. We can take questions in the chat if anybody has questions. Can I start off just by asking
Mhm.
how I do have a question about the venom immunotherapy. How effective is it? And does it, when you say, is it effective in that it reduces reactions, or does it,
Um,
if somebody is on it, does it absolutely take away the effects of the
well,
systemic
that's a great question, because venom immunotherapy is remarkable on both counts. Uh, when I say it's the most effective type of allergy shots in existence, it is for both reasons. It is, and does depend on which venom we're talking about. So first of all, let me answer your question. Um, it's interesting that when we talk about allergy shots for hay fever, we say, well, if you have half as much sneezing, that's a great response. With insect allergy, what we define as efficacy is zero systemic reaction, not one hive. You can have a local reaction, but no systemic symptoms whatsoever. That's effective. So that's one big difference. We go for full efficacy, not just partial improvement. And we still achieve 98% efficacy with the yellow jacket and hornet venoms, only 80% with the standard dose of honeybee. But
Mhm.
the people who do react almost invariably have a much milder reaction than they had before they were treated. So, you know, in the old days, and there's a long history to this, that would have been called a successful treatment because it was less severe. We no longer accept that. We want zero reaction.
Wow.
And with
Okay.
honeybee, since that's obviously of interest, um, although it's not in the guidelines now in the U.S., we're working on a new set of guidelines, and this I can't say for sure that it'll change, but um, I really promote the idea that if that beekeepers with bee sting anaphylaxis should be, if they're going to get the shots, they really should be on double dose because we can give greater than 90% protection with a double dose. Why settle for 80% protection?
Mm. Okay. Okay, so we have some questions coming in. The first thing is, if my brother has a strong reaction, am I more likely to have one in the future? So I guess this is getting to, is there
Mm.
a genetic component to being anaphylactic and being allergic?
So no, that's, although um, what we call the atopic diseases, hay fever, allergies, cat allergy, dust allergy, asthma, and eczema, are all things that run very, very strongly in families. Uh, Penicillin allergy and bee sting allergy are two examples of things that uh, have little or nothing to do with family history. Yes, it can happen, and actually, all of this research that started at Hopkins in 1972, actually, and I joined the team in 78. Um, it all started because of a family of beekeepers in central Pennsylvania,
Mm.
uh, where uh, and there was a previous type of allergy shots called whole body extract that was, and this is where they would say, oh, well, if you were improved, that was successful. There were a lot of misconceptions that made it appear to be effective. But one of the kids in that family died of bee sting allergy after being on the shots. And the beekeepers appealed to through the beekeeper networks with a guy, Al Benton, in uh, Penn State College Park agriculture. Um, and that was the beginning of venom immunotherapy. They purified the honeybee venom. The other kids in the family were the test cases. And you can imagine the fear in the family when they had their shots and then they came in for a test bee sting to prove that it worked, and it did. It worked. So that's how venom immunotherapy came to be, and it was a family. And I've been aware of now and then of a family where it seemed like everybody was affected. But in our research, 95% of people with insect sting allergy have no family history of insect allergy.
Oh, okay. Okay. So this actually gets to, I guess the original bee stings, the immunotherapy was, as you said, freeze-dried bees. So Tim is asking, is the pure bee venom used in immune therapy scrubbed or filtered clean and then freeze-dried? How is it prepared, I guess?
Yes, and don't know all the details, although I can always send you a copy of an article that I was one of the authors on that describes it in more detail. Um, but yeah, honeybee venom is collected by electrical stimulation. So it is the venom and only the venom. Um, and that is further purified by dialysis, by trying to remove some of the chemical agents, some of the things. Venoms contain things like histamine and kinins that cause itching and pain and swelling, but have nothing to do with the allergy. So that removes a lot of those things from the venom, so it becomes less bothersome, if you will, at least to non-allergic people. Um, but it's not as highly purified as we'd like. I'll leave it at that. But it's still considered purified venom because it is venom. And for yellow jackets or hornets or wasps, they actually microscopically dissect out the venom sacs and take out the venom. So unlike the whole body extracts that were the only treatment from 1930 till 1979 when venom was approved, um, the venoms are purified except for fire ant. Fire ant is a whole body extract, but it contains enough of the venom proteins to actually be useful for testing and treatment.
George is asking, what immediate treatment do you recommend to apply to the sting area? Some people use honey, Vicks, vapor rub, propolis tincture. What was you as far as an immediate treatment? You mentioned Benadryl as not being, is that not a good thing to use? But George's question is basically what immediate treatment do you recommend?
Well, Benadryl orally or any other antihistamine is going to take, depending on which antihistamine it is, 20, 30, 60 minutes to work. But it will reduce itching and discomfort. So it's not ineffective for some of these normal symptoms of an insect sting, but it won't prevent allergic reactions. No. As far as what to use, most of the things you mentioned, ranging from toothpaste to baking soda, are not effective. The only thing that should be effective, and there's not much of any real research data to prove it, is something that breaks down the protein, a proteolytic enzyme. So meat tenderizer, for example, if it is the true meat tenderizer, the kind that contains, it used to contain papain as the enzyme, but then people got allergic to that, so they changed it to bromelain. That's a true meat tenderizer. So if you happen to be carrying around in your back pocket a paste of meat tenderizer that you made in advance, and you can smear it on fast enough, it probably will break down some of the venom proteins and reduce some of the local reaction.
A paste of meat tenderizer?
Yes.
Okay. Okay, that's the
Okay.
okay. Got it.
That because nothing else has any ingredient that I mean, anything that's cooling is helpful. That's why, calamine lotion. I mean, yes, it contains Benadryl, but the only reason it works is because it cools the skin. You can use witch hazel, you can use alcohol, you can use a cold compress. Actually, you asked me what I recommend? Ice packs.
Ice packs. Okay. Okay.
And
Great.
talk about scraping, and when the stinger is left in the skin, what about scraping it out with the edge of your fingernail or a credit card or something so that you don't squeeze the venom sac? Yes, but research showed that the venom sac empties within less than 20 seconds. So if you're fast and you can scrape that stinger out of your skin in 5 or 10 seconds, then you will reduce the amount of venom that is being injected into the skin.
Okay. But after 20 seconds, it's all in your skin anyway. It's done. Right.
Yep.
Oh, okay. Um, okay. I don't see, okay. Some people are saying that, they have chamomile essential oil to be really beneficial. Is there anything to support chamomile essential oil that for a bee sting?
Not that I know of, and but I'm very quick to say I don't know that it helps, and I don't know that it doesn't.
Mhm.
So I'll leave that wide open. And there are many things that fall into that category that There are proponents who say a lot of things are helpful. I'm going to just say, are we talking about things that make it more comfortable, most of which are just because they have a cooling effect? Or is there something that can actually reduce the chance of an allergic reaction to the sting, of which, to my knowledge, there is not?
Okay. Um, this person is asking about a penicillin allergy. If I was told I had a penicillin allergy as a toddler because I developed hives, must I continue to avoid penicillin forever? Is there a test to determine this? This is getting a little off
Okay.
the.
I'm really glad you asked that, because this is actually a nationwide um, priority. Uh, in fact, if you are unfortunate enough to land up in the hospital for any reason, you're likely to be asked about that label on your chart that says you're penicillin allergic, because they'll want to delabel you. We now strongly recommend that if you have that history that you're supposedly, and I'm going to use the word supposedly, penicillin allergic, you need to be delabeled, because there's a greater than 95% chance you will not react to penicillin now. And for years and years and years, we've been doing allergy skin tests, which are available for penicillin, but not accurately for other drugs. But the latest recommendations, the guidelines that were published in December 2020, now in almost all cases recommends a simple test dose. Come into my office. I'm going to give you a 250 milligram capsule of amoxicillin. You're going to sit there for an hour, and if nothing happens, you're good to go.
Mhm. Okay.
And
Okay.
the exceptions are people who have had very severe reactions and very recent reactions. But if it was years ago and it wasn't all that severe, then there's a overwhelming likelihood that you're not going to react, and not react severely, to the test dose that we would give you under the supervision of an allergist or any other doctor that's willing to take this on.
Okay. Okay. For some, Chris is asking about for skin testing, is the dose titrated to the full 50 micrograms that you would get in a sting? This person is saying, my dog has anaphylactic reactions and is getting skin testing in December. Do you take any
Hmm.
precautions when starting actual therapy, like placing IV catheters?
Several questions in there.
Yeah.
And that's good. That's okay. So skin testing, um, is the idea of skin testing is to use a minute amount of the allergen, enough locally in the skin to cause a little itchy bump, which is what a positive reaction looks like, but not enough to cause a generalized reaction. So, no, skin testing with venoms introduces uh, 0.02 mLs of about 2 to 4 1/100ths of a microgram of venom.
Very, very small. Okay.
Whereas a honeybee sting, I said, introduces 50 micrograms of venom into the skin.
Mhm. Okay.
Now, the treatment, on the other hand, the whole idea of immunotherapy is to build up the dose from that very, very small dose, gradually up to higher and higher doses. As your body adjusts, you become resistant to the reaction, and pretty soon you're getting doses of 100 micrograms, equivalent to 2 honeybee stings. Although I said I prefer the 200 microgram dose in beekeepers, um, and not having reactions to it, because you've built up a resistance and you no longer get reactions to it.
So once you build up that resistance, do you have to have a maintenance dose for, I think you said something in your presentation about 5 years? Do you have
Yes.
to continue to get those maintenance doses, and how long,
So we
how,
can build up the dose, the initial treatment, depending on the allergist. We use a program that builds up with a shot once a week for 7 weeks. Many allergists will do that much more slowly because they're so afraid of reactions. And I understand that both patients and doctors are afraid of reactions, and they'll build it up over 4 to 6 months instead of 7 weeks. I have to point out to them all the time that we actually see more reactions with that slower regimen than we do with the so-called modified rush or rush regimen. A rush regimen is where we can have you immunized in 3 days.
so the rush
You'll
regimen
spend
can
all
be
day in the clinic
uh-huh.
for the first 2 days, and then come back for the final dose on the third day, and then you're immune. But then, yes, you have to get a maintenance dose once a month, is what's recommended, but we spread that out to from 4 weeks to 6 weeks to 8 weeks to 12 weeks over a period of 2, 3, 4 years. And then after 5 years, most people can stop. There are a few who have known high risk factors that we would encourage them, including beekeepers with severe reactions, because frequent exposure, I've said, is one of the risk factors for getting allergic and for having more severe reactions. So in beekeepers with moderate to severe reactions, we actually recommend extended treatment, which means for as long as you're going to be beekeeping,
Mhm.
even forever. But 4 shots a year makes it not such a bad deal.
Mhm. Okay. Vincent is asking, is the main allergen phospholipase A2?
Yes, in
Okay.
honeybee, in
In
honeybee,
honey.
not in
Okay.
not in the other insects.
Okay. Um, Mike is asking, I've read that one can become more sensitive to bee venom from contact over time instead of injection through sting. The example is a beekeeper's wife handling his suit that's been stung and loading the washing machine. Have you heard of this? Can you get allergic just through contact, skin contact?
Hmm. I would love to test that beekeeper's wife, uh, but with whole body extract. Is
Uh-huh.
so? First of all, you know what? There's an interesting question. I'm not aware of contact dermatitis of the skin to venom, but I don't see why it couldn't happen. But I am aware of allergy, and again, I'm not sure about the contact part of it, but I'll bet it does happen to what's called bee dust or hive dust, which has a lot of the body proteins. So that whole body extract was useless for venom allergy, but it does contain the body proteins that beekeepers can get allergic to from breathing the dust. So there are beekeepers who get sneezing, itchy eyes, runny nose, coughing, wheezing, and asthma from hive dust. That's a respiratory allergy, and it's from body proteins. So, what was on the beekeeper's suit? Venom, probably. Other bee products, maybe. Bee body proteins, certainly. So, something is causing her to react, and I'm not sure which of those things it is.
Mhm. Somebody is asking if your allergy score is 960 of 1000, would you carry an EpiPen? This person is asking specifically about a shellfish allergy, though.
I've not heard that terminology before, so I'm not sure who has created this allergy score. Um, again, I don't know what that is.
Yeah, the
There,
person asked that question. If you want to come off of a microphone and ask directly, that feel free to do that.
you can, or you can email me, and I'll be glad to answer it. People get told a lot of things, um, because it could be that is that the description of the blood test or skin test result, although I haven't heard it expressed that way, and I've already said that test results don't accurately predict how severe a reaction will be. Is it based on the previous history? I outlined the things that we know do predict, basically the history and the test results, but
Mhm.
I don't know what that score is supposed to be.
Mhm. Okay. When you do have effective immunotherapy, does your IgG go up and does IgE go down?
Yes and yes.
Yes and yes. Okay. Okay.
But the IgG does go up. Um, but after a few years, it is no longer the important factor in the immunity, which is why when you stop the immunotherapy, the IgG goes back down again. But the immunity doesn't necessarily disappear.
Mhm.
So IgG is only part of the story when it comes to immunity, but it's a very important part of the story in those first couple of years. It does go up. The Ig goes up initially, and then after a year, it starts to come down, and by 4 or 5 years is way lower than it was at the beginning, and occasionally, but rarely, actually goes away completely.
Mhm. Okay. Okay. So if you suspect, you mentioned about not over testing. So if you do suspect that you have a bee sting allergy and you go to your physician, should you refrain from asking to be tested like just indiscriminately? Is there an over testing situation going on, or like what should you do if you're fearful about this?
You know, it's a hard question because I don't want to discourage the testing, but I don't want testing to lead to fear unnecessarily either. So the one thing that's clear is that if you had a reaction to a sting where you had any trouble breathing or felt like you were going to pass out, you need to be tested and immunized. That's the easy part. Anything else, I would say you don't require treatment if you broke out in hives or um, had a large local reaction, or you have a relative who had a severe reaction. I mean, none of those are high risk, but they are open to discussion, like in the beekeeper who has frequent stings and maybe uh, should consider being tested or immunized because they're tired of having large local reactions, uh, or breaking out in hives every time they get stung. Uh, what beekeepers, on average, find incidentally is that the reactions are mainly early in the season. If you do get stung a few times or more than a few times during the season, you're really self-immunizing. So I've encountered a number of beekeepers who uh, the the first the first one or two stings of the season they may get a reaction, and then they're fine for the rest of the season. Then they don't get stung all winter. So then the next season they have a reaction again at the beginning of the season. It's been proven that you can self-immunize if you get in the range of 100 to 150 stings a year, uh, ideally 2 to 3 stings every 2 to 3 weeks year round.
Hmm. So you're immunizing yourself just by
You
getting
can. It
stung.
is effective. If you
Uh-huh.
if you can stick to that regimen, you can self-immunize. Yes.
Okay, okay. So we'll just take one last question here. Is the longer term immunity cell mediated then? I am not sure.
The long-term immunity, I'm sorry, is that the question?
Uh, yeah, Ellen, do you want, if you want to come off of mute and ask, I'm reading the question. Is the longer term immunity
Yeah.
cell mediated?
Um, yes. I guess the short answer is yes. It's immunoregulation has a lot to do with the T helper cells, the T lymphocytes, so that's cell-mediated immunity, and the way in which they regulate the response in your system to balance it out ideally, because that's what we want. There's a yin yang in the immune system that it makes you have more or less risk of allergy, but it can be overbalanced, so to speak, into having more risk of autoimmune disease. And that's oversimplifying, but uh, yes, if you are genetically programmed to respond for your T lymphocytes to respond by making allergic antibodies against something, uh, allergy shots, immunotherapy kind of deprograms that and restores if it's fully effective, then within 3 to 5 years, um, it there are those cells release cytokines. If for any of you who and whoever asked the question, yes, interleukin 10 is the marker for successful immunotherapy in the early months and years of immunotherapy, and that's the way that those lymphocytes are responding to regulate the system later in immunotherapy. That IL-10 has actually gone. No one has yet clearly shown what that long-term immunity really depends on. And this is becoming really important in the peanut allergy, for example, because now there's oral immunotherapy for peanut allergy, but uh, no one has yet described a permanent kind of immunity. Tolerance is the holy grail of immunotherapy for allergy, is to get you to be like the non-allergic person, totally tolerant.
Mhm.
And we don't know what exactly makes that happen.
Okay. I don't want to
Thank
keep
you.
oh, thank you. Yeah, I don't want to keep you too long, but these are two great questions that just came in. Are there any drugs that can aggravate the reaction to stings and therefore a concern for beekeepers?
Yes. Um, in a way, um, common medications used for blood pressure, for example, beta blockers and ACE inhibitors, lisinopril is an ACE inhibitor, metoprolol and, is an example of a beta blocker, are known to increase the chance of a reaction, not a higher chance of having a reaction, but a higher chance that if you have a reaction, it's going to be more severe.
Oh, okay.
So yes, there are medications that can make a reaction more severe than it would have been if you weren't on the medication.
Okay. Okay. And we're going to take just one last question here. Do you take precautions when doing immunotherapy, like IV catheters in the office, or can you give injections uh, as a patient or at home? Chris, do you want to come off mute? And did I get that
So
right?
I'm sorry I didn't respond to that. Let me jump right in, and then I'm happy to have someone elaborate if there's another aspect to it. But I should have definitely answered that part of the question. Um, Venom immunotherapy is not any more risky and is than other allergy shots. And in fact, I see more systemic reactions to cat or grass immunotherapy than I see to venom immunotherapy. So no, we don't take any unusual precautions. You come in, you get your shot, you wait 30 minutes, and off you go. It's unlikely, but not impossible, that you will have some reaction to a shot. You could get itchy all over, or break out in hives, or even have a full-blown anaphylactic reaction during that build-up stage where we're building up that dose over a period of weeks or months. It's so immunotherapy does have some risk. It's not a high risk. It's mainly during the build-up stage, and it's no different with venom than with any other allergen. And the main and really only precaution is medical supervision. No, you shouldn't do this at home. And we've even discouraged, we've had doctors who said, oh, can I give my kid the shots at home? I'm a doctor. And the answer is, well, if you have intravenous fluids and oxygen at home, go ahead.
Okay. 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 All right. Well, I think we're going to wrap it up. Thank you so much, Dr. Golden. This was wonderful, a really, really valuable session. I think I hope everybody enjoyed it. And thank you again so much. Really, really appreciate your time.
I'm happy to have you post my email address because I certainly don't mind answering questions.
Thank you so much for joining us again. Thank you so much, Dr. Golden.